Hey everyone, thanks for joining Baltimore County Fire Department EMS Training Academy. For those who I haven't had a chance to meet, my name's Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I'm an active member at Pikesville Volunteer Fire Company, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of the medical director's office and Dr. Pollack, on behalf of the EMS office, Director Shedding, Captain Stewart, Captain Natz, thank you for what you guys do every single day. Thank you for your dedication to lifelong learning. Also, a big shout out to Ashley Brooks, who is a young member volunteer at Pikesville Volunteer Fire Company. Ashley helps us run this online platform. Ashley also is the one who sends out the link to get your CEUs in the chat. So keep an eye on the chat function. Ashley will send out a link. Click on that link. It takes 2 seconds to enter some basic information, and we'll make sure that you get your CEUs. What we're not able to do anymore is to be able to log in by phone and let us know that you participated after. Unfortunately, MIEMSS definitely wants us to be signing in on the platform. So please connect with Ashley or me in the chat function before this presentation is over if you're having any challenges with signing in to get your CEUs. Great, so tonight we have the honor of having Dr. Marcie Feinman with us. Dr. Feinman is the Associate Division Chief for Acute Care Surgery and the Program Director for the Surgical Residency at Sinai Hospital. She has a strong background in education, having completed her master's in education for the health professions from Johns Hopkins in 2017. Additional training included medical school, George Washington University, general surgery residency at New York Medical College, and both surgical critical care and acute care surgery fellowships at Johns Hopkins Hospital. Dr. Feinman utilizes her knowledge and expertise in curriculum development to enhance trauma simulations, improve trauma morbidity and mortality, and co-chair the Trauma CME conferences. She's an engaged speaker and often receives outstanding feedback on her talks, local, national, and regional conferences. I've also learned that, like me and so many of us, Marcie got her start in the volunteer EMS service a few years ago. So Marcie, thank you so much. Oh, and also Jamie Gannon is with us also. Jamie is the trauma program manager at Sinai. So he's helping us build this partnership and this relationship, this ongoing and growing relationship with Baltimore County Fire Department. So Jamie, thank you also for joining us. Marcie, thanks for joining us. Thanks for sharing your time and your talent. And what I love is your passion for education. So for that, I'm super grateful. Thank you so much.
Well, thanks. This is going to be fun. I'm excited. I've given this talk a few times, but never over Zoom. So we're going to have to see how it goes. I'll ask before I start. There's so many people on here. However many feel comfortable turning their cameras on, that would be awesome, because I like looking at people, and I usually do this in person where I can look at people. So cameras on is fantastic. I got like 3 more. All right. I even see a few names that I know on here, which is exciting. So yeah, Dr. Barinholtz gave you a really good background about me. What he didn't really mention, though, is that he taught me a ton of what I know, actually, because when I did my fellowship, at least one of them, over at Johns Hopkins, Dr. Barinholtz was one of my faculty back in the day, and we reconnected in the Sinai Trauma Bay. So go figure, it's a very small world. So this talk is usually very interactive. We're going to see how that goes over Zoom. Does everybody know well, if you don't, I'll give you a little thing. On the bottom, if you hover your mouse over the bottom, you're going to see things that say share screen or chat or reactions or participants. Everyone see that? Can I get like a thumbs up from the people that I can see on the screen? Okay. If I ask questions, you are welcome to unmute and actually give answers, or if I ask for a vote, because there will be voting during this, if you click on the participants button, you can raise your hand. So if you click on participants, you'll see something that says raise hand. And if you do it, I can see how many people vote for different things. Once we're done, I'll ask you to click it again so it goes away for the next one. Everyone with me so far? So far, so good. All right, I'm going to make a concerted effort here to share my screen. So give me 1 sec. I realize this looks weird. You're looking at all of yourselves. That's intentional. And okay, everyone see my screen? It should say point of care ultrasound for trauma. Perfect. And I'm going to move you guys over to my other screen so I can see all of you as we go. Thank God for Zoom, huh? All right. Okay, perfect. All right. So here we go. I have no real disclosures, okay? This is not a disclosure. I get no money from this book, just FYI. If you are interested in ultrasound in general, check this one out. The chapter about point of care ultrasound for trauma is fantastic. I guess my other sort of disclosure specific to giving this right this second is that I am giving this talk from my house. I have 2 very small kids that are hopefully eating dinner and going to bed, but if they wander in here during this, I apologize in advance. So here we go. This is the plan for today. We're going to discuss the indications and utilization of the EFAST exam. FAST stands for Focused Assessment and Sonography for Trauma. Okay, this is very case-based. It's learning as we go. As far as I know, and Dr. Barinholtz, and I saw Dr. Sagel jump on here, correct me if I'm wrong, but you guys aren't using the butterflies or ultrasound in the field yet, are you?
Oh my
Anyone?
God, we're not even using them in the hospital.
I wouldn't be surprised if it translates eventually. But, you know, the reason that I give this talk to EMS especially isn't because you have to understand the ins and outs of ultrasound by any stretch. It is more so that you can understand when you bring patients into the trauma bay, how we make decisions once the patient gets there and what we decide to do for them. So that's kind of what we're going to spend some time on. Okay. So we will discuss the novel uses of point of care ultrasound. Well, we'll probably skip the critical care part because I don't want to take up too much of your time. We're going to focus mostly on trauma today. So this is a lady named Grace Ruzicki. She founded the FAST exam. She, I think at the time, was down in Atlanta and was like, okay, well, when people bleed, where do they bleed into? If you're internally bleeding, where does it go? It goes to places that are dependent. And the places that are dependent in your body kind of live between your liver and your kidney, your spleen and your kidney, down around your bladder. And then we can also see fluid around the heart. And we will look at pictures like that and was like, okay, well, an ultrasound machine is fast, it's portable, it's easy to have at the bedside, it requires no radiation, you don't have to move the patient. And so maybe we can use that to help with decision making. So here we go. When we do a FAST, first thing we do is try and get our pictures. We look in 4 places, okay? The first one is at the heart. So this is kind of just below the xiphoid, aiming up towards the heart. The second one, left or right upper quadrant. This is left upper quadrant here. Third is down in the pelvis. Fourth is the other quadrant, whichever one you didn't just do. After that, we put our probe on and we have to figure out what's going on with these images. So when we put the probe up by the heart, this is what we're looking at, okay? Right ventricle, right atrium, left atrium, okay? What we specifically are looking for is fluid around all the ventricles. That's what we're looking for. Fluid in trauma is blood until proven otherwise. And so that's what we want to see. If it's there, that's a problem. If it's not there, great, but it could be operator error also. We'll talk about that. When we're looking in the left upper quadrant, we're looking between our kidney here and our spleen here, okay? And we're looking for fluid around this. When we're looking down in the pelvis, we're looking all around the bladder to see if there's fluid. And when we're looking in the right upper quadrant, we're looking between the liver and the kidney. These are all normal pictures. Keep these in mind. That'll be important as we move forward. And then we have to decide what we're going to do. So here comes decision making. Okay, we need to see If there is fluid, okay, fluid usually on ultrasound shows up black, okay? This pericardial effusion is pretty terrible, but normally it's black. Here's a better one. We're looking kidney, spleen. See this black rim right around here? That's fluid where it's not supposed to be. Fluid in trauma, we assume is blood until proven otherwise. Okay, coming back down here towards the pelvis, now we have bladder, and all of this stuff right around here is not normal. All that black is fluid that's not supposed to be there. And then we're going to the right upper quadrant. We have liver here, kidney here, this big black stripe right here. Not supposed to be there, okay? So based on this, plus our patient stability, gives us an idea of what we want to do afterwards. The EFAST, so that used to be the regular everyday fast we do on almost every trauma patient that comes in. And then people got all like fancy and decided to add an E to it. The E is for extended fast, and this now looks at the lungs, okay? So ultrasound is actually more sensitive than even X-ray for looking at things like pneumothorax. It's very good for that. So you take this big fat transducer and you put it on the chest and you're looking at the pleura, either on the right or on the left. And here's what you're looking at, okay? These are all normal pictures. Again, keep normal pictures in mind. So we call this kind of like the rocky shore. It looks like an ocean. Ocean is normal when you're looking at lungs. Okay. This is your heart, again, no fluid around it. This is your left pleura, same idea, your rocky shore looks great. Right upper quadrant, so liver, kidney, pelvis, bladder, no fluid around it. Left upper quadrant, spleen, kidney. So here we go. Everyone good so far? We know what's normal, we know what it's supposed to look like? Yes? I'm going to take silence as a yes. Okay, perfect. So here we go. We're going to go through a whole bunch of cases, and you're going to tell me what you think we should do for these patients, okay? There's zero expectations, that's fine. If you want to speak up, saying, I don't know, phoning a friend, totally fine, acceptable answers. I suggest either Dr. Barinholtz or Dr. Sagel as options for friends if you're going to go that direction. And hopefully this is fun and it like actually solidifies some knowledge as we go. So here we go. Number 1, single stab wound, left thoracoabdominal region. Okay, it's a bad location for us. We're usually going to the OR for things like that. The decision to be made is when and what we're going to do. So these are the vitals you give us. You wheel this patient in, he's already intubated. You tell us your most recent set of vitals, heart rate's 130, blood pressure is 94/70, respiratory rate's 18, O2 sats 99%, but you have them on 100% oxygen and you're bagging. We hear equal breath sounds. We don't see any external hemorrhage at this point. So, important things, right? Heart rate in the 130s, blood pressure in the 90s. This patient is not particularly stable, right? That makes us worried to begin with, especially with this area of injury. So we have a penetrating injury that's non-cardiac. It's outside what we call the box, and we'll talk about the box in a little bit. And this patient is unstable. So here's where our fast comes into play, okay? So I'm gonna show you some videos. Here is your right pleura, okay? I'll play it again. This is the patient breathing, and your right pleura, okay? Here's your heart, here's your cardiac window. Remember, we're looking for blood, the black stuff where it's not supposed to be. Here's your left pleura. I'll play it one more time because it's a little slow. Okay. Here's our right upper quadrant over here. And the video is us kind of fanning through with that ultrasound probe. Here's the bladder, so pelvis, we're looking down in the bladder, fanning through. And here is our left upper quadrant. So, anybody brave enough to unmute and tell me if they see blood on this ultrasound? By the way, I teach a lot and I can sit here for like an hour waiting. Frank, you're unmuted, so you win.
I think the pelvis, it looked like the one from your example.
Correct, yeah. So pelvis has blood, all this stuff right here, not supposed to be there. Anyone else see blood anywhere on any of these other pictures? Any takers? You can throw it in the chat too, by the way, although I don't know if I can see the chat right this second. Oh, maybe I can.
The left upper quadrant don't
All
look clear.
right.
The cardiac doesn't look. One of the chambers don't look that. I can't find one of the chambers.
Okay. All right. So thankfully, at least with so I'll play your cardiac one again if you'd like. So 1, 2 is right there, 3, 4. So all the chambers are there, maybe a little underfilled, but no fluid around it. But I heard you say left upper quadrant, right? Is that what you said?
Yes,
Or
that was my first choice.
correct. Okay, yeah. Certainly correct here, right? So here, I'll let it like kind of pan through for a sec, but even when it stops, so all this over here, this is all blood. Any others? Any other pictures that you see blood?
Right upper quadrant.
Right upper, that's a big one, right? All of this black stuff right here is blood, right? This is like kind of like the tail of the liver just like flapping in the breeze here, and a whole bunch of blood right around it. So we look at our ultrasound in the trauma bay, and now we know we have a patient who has a stab wound, thoracoabdominal. Oh, and the other important thing is that the pleura, both of them are normal, okay? So this patient has a thoracoabdominal stab wound, which likely is only abdominal, right? We don't have a pneumothorax. There's no fluid in the chest, so there's nothing we need to do about the chest, but the patient's unstable and has a bunch of blood in the belly. So just from that alone, our next decision is that this patient goes to the OR. Okay, they don't need any more imaging. They don't go get CAT scans. They don't do any of that. They go from the trauma bay and they go right upstairs and go to the operating room and get surgery. And these things are kind of, I mean, this is one of the best parts about my job. Obviously, I like not, you know, it's a surprise. Every time you go, it's kind of a surprise. I can't tell you what's injured yet, although left thoracoabdominal, my money would be on the spleen. But you get to go and figure it out when you're in there. And that, at least for us, is fun. That's why we do this job. Any questions about that one? No? All right, we got a few more to go. So here you go. Number 2, motorcycle crash, helmeted, going city speeds. You wheel this patient in, you tell me there's a heart rate of 125, blood pressure 95/60, respiratory rate of 28. O2 sat is 95%. Now, of course, it is super loud in the trauma bay, as it always is, because it's, I'd like to say organized chaos, but probably realistically just like chaos. That's probably real life. And so, you know, we know the patient can kind of talk to us. No idea about breath sounds. We like to, maybe we hear them, maybe we don't. Chest is really tender. Pelvis is stable, belly's soft, no obvious external bleeding, okay? So we know the patient's not the most stable to begin with. This is a blunt trauma patient. So we do our fast. So here you go. Let's look, this is our right pleura over here, okay? This is our heart, cardiac window right here. Here's our left pleura. It's really great having 2 pleuras because you can always compare them. It's nice when patients have 2 sides. Here's our right upper quadrant and our pelvis and our left upper quadrant right here. So, which, if any, of these boxes are abnormal on this patient?
Right floor.
The right
Yes.
floor.
Pick me. No, Jeff, I'm not picking you. Yes, the right pleura. It's very abnormal, right? It doesn't look anything like the left pleura. And we said earlier that this left pleura is normal, right? So this means there's likely a lot of blood in here, okay? We see all this black stuff. It's not looking normal. And we have an unstable patient. So this patient gets a chest tube right away in the trauma bay. Okay, we don't even need our x-ray to see that. There are fancy measurements. So this is like one of the ways you can do all kinds of stuff with ultrasound. We don't really need to do all kinds of stuff with ultrasound in order to just guide us towards what the most appropriate thing to do with these patients are, but we can. So you can measure and you can find out that there's about 1,500 cc's of blood, so 1.5 liters of blood in this patient's chest. Does knowing that change what we have to do? Not even a little bit. Patient's unstable, we know there's blood. That's all we need to know. Good enough. Patient gets a chest tube. If it puts out a whole bunch, like a whole bunch, maybe they need a whole bunch of blood. So we have massive transfusion protocols in the hospitals that get activated right away if patients need blood. And if they really bleed, like a lot, and for us, our requirements are more than 1.5 liters out of the chest tube right away, or more than 200 milliliters per hour over 2+ hours, they go to the OR and they get a thoracotomy. We operate on their chest and figure out what's bleeding. Good? Questions? All right. I'm going to go with so far so good.
Were there more of the images were abnormal too, right?
Sorry, I'll go backwards. Nope, the rest of these are all normal. Okay, so cardiac window, you're looking at chambers right here. Okay, so all that blood is in the heart, not around the heart. This left floor is a normal one. Right upper quadrant, here's your kidney, here's your liver. There's no blood around that. Okay, I know somebody said something about the pelvis. This is your bladder that you're looking at right here. It just happens to be more full than others. So if people really need to pee, that bladder can be big, but it's all very well contained, right? This is well contained in a circular structure there. That circular structure is your bladder. And then left upper quadrant over here, here's kidney coming in, and here's your spleen, and there's no big dark stripe right around here. There's a little bit of shadowing, right? So ultrasound, I kind of alluded to earlier, ultrasound is very operator dependent. And we say in order to get really good pictures on fast, you have to do at least 50 to 100 of these to be really good at it. And every patient is made differently, and depending on how big, like big meaning long their torso is, you know, or how tight together their ribs are, all of that affect the quality of images that you get. Because if you end up with your ultrasound right up against a rib, you're going to get rib shadows. Okay, ideally rib shadows are kind of gray and not black. But these take tons of practice to actually like be good at, both good at getting the images and good at interpreting them. All right, let's go to this one. Motor vehicle crash. Okay, so we're at blunt trauma right now. Belted, highway speed, clearly unstable, heart rate of 140, blood pressure is 85/60, O2 sat is only 85%, so patient gets intubated in the field. Breath sounds are bilaterally decreased, you have crepitus, abdomen's distended, no external hemorrhage, but this patient is clearly in extremis. Okay, so blunt trauma, totally unstable patient. So we do a couple pictures here, okay? I'll do both pleura first, okay? So this is your right side as we go through here. And this is your left side. So to start, do these two look the same?
No.
No,
No. Which one is the abnormal side?
I would say the right.
Correct. Yeah. The right side's your abnormal side. Okay. So this is your nice rocky shore. Okay. Everything kind of slides nicely. There's no, you have a little bit of interruption here on your rocky shore picture. And you see the kind of the whole screen moving as one. Okay. That means the lung can't slide. So there's something in between the lung and the chest wall. Okay. So this needs a chest tube, but we'll get there. Here's our heart. Okay, yay or nay? Good, not good? I'll play it again.
That's good. First
Any,
one.
any
Is
votes,
there
you
fluid
guys?
on the bottom or the outside, or is that the shadow?
That's a shadow.
Okay, that's fine then.
Yep. Okay, how about this one, our right upper quadrant? Show of hands, how many people think there's blood in this right upper quadrant? You can either raise them or raise your E hand. Okay. Yeah, I got a thumbs up. Agree, agree. Okay, so yes, definitely blood here. How about the pelvis? Any blood in the pelvis? I'm getting some shaking heads, and I would agree with you. I don't see any blood there either. How about this left upper quadrant? This one's a hard one because there's a shadow that comes through right in the middle. Yay or nay? Show of hands or thumbs up here. Votes for blood. I got a not so sure. I have some hands up. I don't know if these are residual from last time or not. It's hard for me to say. And again, you could call this equivocal, but I think I would call this positive. And I think there's blood right around here as we scroll. Okay. But you now have a fast, and again, we call the fast positive. You only really need one of these pictures to be positive and show you blood to have a positive fast for decision making, right? So this patient, for us, gets a chest tube on this right side, right, in the trauma bay, and then goes right up to the operating room to look in the belly for the blood that we know is there. Okay, so these are the differences in the two pictures that I showed earlier. This is normal, so there's no pneumothorax right here. And this is a pneumothorax. See the top, this line and these all moving together when the patient breathes? It's a little subtle, but I'll play it again. See everything all moving together? One more time. When it all moves together, that means the lung can't slide. It's not against the chest wall anymore. Okay, so there's likely air. Could be blood, but likely air in there. So this patient gets a right chest tube. Again, vital signs get a little bit better, but still unstable. And since we said that the fast was still positive, the patient goes upstairs to the operating room. So now we'll talk about the cardiac box a little bit. This patient has a single stab wound to the right anterior chest. Unstable by vital signs here. Comes to us already intubated, which is lovely. Breath sounds are equal, and there's no obvious external bleeding. So this is within the cardiac box. And we define the cardiac box as anything between the clavicles, nipple line, costal margin, both anterior and posterior. A lot of times people forget about the posterior, but your body is 360 degrees. So any of those, we have big, bad, really important things within those areas. And so if we look at this, here's our right chest, and here's our left chest, and those look the same, which is nice. So those are both normal. What about the heart?
Blood
Jeff,
in it.
yeah, well, there's blood around it, right?
Right.
Jeff, now would be the time to speak up if you want to. All right, I'm going to take that as a no. So yeah, lots of blood around it to the point where the heart almost looks kind of like it's just flopping around, right? It's not like expanding, contracting. And when we talk about things like cardiac tamponade, this is what it looks like. There's so much pressure outside the heart, right? So this is your pericardium right here.
This is special.
What'd you say?
I'm unmuted now. This is one of your specials.
This is one of my specials. You're not wrong.
No, I get called in for this all the time.
Yeah. So here's your pericardium, right? And here's your actual like heart muscles, and all of this fluid that's in here doesn't let your heart actually expand to fill its atria and ventricles, right? That's why one of the things you look for, at least one of the signs, at least in the field, for cardiac tamponade is narrowed pulse pressures, right? Because the heart can't fill, so it can't contract. So the difference between your systolic and your diastolic starts to go down and down and down and down until they're like the same number, and then the patient's dead, right? Tamponade, cardiac tamponade, can happen with a very little amount of fluid, as little as 50 cc's, if it's really fast, okay? If it's like an acute injury, super fast, tamponade can happen with a little bit of blood, and relieving that pressure is really important for patients, okay? So we know that this is not great for the patient. So lungs are okay, heart not so okay. Belly, I'll play these because these are important too. Even though it's in the box, you don't know the trajectory of the knife, right? It could have gone down through the diaphragm and hit something else that's important in the belly. Maybe something over here, but nothing major. Okay, this is such a nice picture right here. Those almost never happen, but being able to see liver and kidney and nothing between them is beautiful. So this patient, this isn't such a hot video, but okay. What do? We don't, do you guys still, I don't, you guys are mostly BLS, is that what Dr. Barinholtz told me? Do you guys learn about like pericardiocenteses during your training and stuff? We do sometimes. They're very hypothetical. Almost nobody ever does them.
Yeah, I think we certainly learn about it. I don't know that it's a skill that we do in the field.
Yeah, we learn about it too, and it's not a skill that we do either. So if people need the blood around their heart drain, that's not like, oh, sorry, that's not really a great way to go. We like to make big incisions. It makes things easier for us. We don't like little baby needles, so we make big incisions. And for us, you've ever seen those memes that say like the fastest way to a man's heart is through a left anterior lateral thoracotomy? If you've never seen it, you can Google it. They're all over the place, but it's very true. So left chest for us is the best way to get to the heart. And so if this patient came into our trauma bay and was really, ideally, we'd love to get to the operating room, but if they end up like coding in front of our eyeballs, this is what we would do, okay? Open up their entire left chest here to get in, open up the pericardium so that all that blood can get evacuated and let the heart expand again so it can start to pump, and ideally fix whatever the injury is that the patient got stabbed with. If the patient can make it to the operating room, instead of going through the left side, we really like to go right up the middle, right? That's the most direct way to the heart. But that requires, you know, power tools like saws and stuff that we don't keep in the ER, so these don't get done in the ER. All right, change gears just a little bit. Still penetrating trauma, single stab wound, anterior right chest. Now this patient's pretty stable, right? They have a heart rate of 75, blood pressure 120-ish over 70, respiratory rate's fine, O2 sat's fine. They have breath sounds, so like nothing super exciting. Okay, great. We still do our fast, obviously, and where this injury is still worrisome. This is within our box that we talked about earlier, so we worry about heart and big vessels. And so we do our imaging, well, our ultrasound at least. And if we look at the right and left chest, they look the same, so that's great. If we look at the heart, votes for blood around the heart, yay or nay? How many say, I'll play it again. How many say yes by a show of real or virtual hands? Should I play it one more time? I'll play it one more time. I have a couple of real, oh, I got a thumbs up. I got one real hand. I have two, oh, wait. I have one thumbs down and two virtual hands and a ton of people who abstained. Abstaining is not an option. This is a yes or no question. One more time, we got to commit to something, yay or nay. Blood around the heart or not? Oh, I got a couple more yeses. Oh, I'm getting a few yeses. All right, all right. I like the thumbs ups, they're easy for me to see. The whole second half of my screen is not voting, but that's all right. Jeff, you want to vote? I didn't see a vote.
I just unmuted him.
You need it again?
Dr. Sagal?
You
Yeah,
walked away to have dinner.
no, I wish. No, I just ran 3 miles before. No, there's a little bit of blood around the pericardium, but yeah, that could have been physiologic. It's hard to say.
Okay, great. So I agree, right? There's some kind of fluid here. There's like this little band. So all of you who voted yes, I totally agree with. There's this little band here. But what we do about that, this one's a little more complicated because our patient is fine, technically, right? They're not imminently dying in front of our face. And then I will just give you the highlights. The abdomen is fine. No big blood in the belly. So what do? We have to see what that fluid is. And remember that I mentioned earlier that all fluid in trauma patients is blood until proven otherwise. Now, if this patient that came in is, 65 with a history of, kidney disease on dialysis and has some uremia, it may not be blood, but we don't know that until we look. And so we always look. Now, we do not have to obligate patients to big giant incisions like we did in the unstable patients, okay? We can look in the pericardium through an incision like this big. Where's my camera? Like 4 or 5 centimeters. And we can make an incision just below where the xiphoid ends and kind of go up underneath the sternum, lift it up, and get right into the pericardium like that. And if there's no blood, great, we're done. There's nothing else to do, at least not surgically. If there is blood, that's a problem, and then they get their big incision, even if they're stable. Okay, blood is bad around the heart. Any questions about that? Blood is bad? Okay, good. So this patient, kind of similar, single stab wound, anterior right chest, also stable, no external hemorrhage. And now we have these pictures. So we have left and right chest. How many people vote normal? How many people vote abnormal? Joe, I can't tell if you were normal or abnormal because the thumbs up like hangs around for a minute. So these are normal. We'll give you that. Heart. Here's our heart. How many people see fluid around the heart? Show of hands or virtual hands. Remember, after you vote your virtual hand, if you click it again, it goes away, just as an FYI. So heart's normal. We'll leave it at that. Anything in the belly? Anyone see anything exciting in the belly? I know they play slowly. So belly's normal. So we don't see anything. There's no blood. This patient still has a stab wound to their chest. You probably got lucky and it didn't hit anything. So generally there's not much to do. We can wash out and close that incision. An echo is possible, but not necessary, and I probably would not do it in this patient. I would likely discharge the patient home. That'd be me. There are some worries though, okay? Anytime patients have blood in their left chest, our FAST is not accurate, okay? Because if they get stabbed in the heart and have blood in the left chest, a lot of times that blood goes from around the heart into the left chest. So the heart part may be negative while the chest is positive. So you can't rely only on FAST if there's blood in the left chest, okay? Also, if they've had like open heart surgery before, I hope they're not getting stabbed in the chest, but this is Baltimore and we all know that that definitely happens. And so that could also give you some false negatives. So those would be reasons that we would admit and watch them and make sure that there's nothing else that develops. Quick cautionary tale. What is this? Can anyone tell? Chat box, or if you want to come on and tell me.
Bullet wound?
Close. It's not a bullet wound. Let me see if I can give you a
Arrow.
Is it a taser?
taser. No, but good guess.
Dang.
Arrow.
An arrow. We're like warmer on our scale of warm. How about that?
Oh, a nail gun.
It's a nail gun, right? That's a nail gun. Now, please note, there's other important things, right? So we're looking at an x-ray, and this is a lateral view, okay? So we're looking at, somebody took the picture to the side of the patient, right? So this is anterior. This is posterior. Here's the spine. What are these things right here?
Rib cage?
They attach to the rib cage. These like circle-y thingies. Yeah, did you say he had surgery, Joe?
Yes.
Yeah, these are sternal wires, okay? So we had said earlier that our FAST is not like totally reliable if people have had open heart surgery before for some reason. And this is what it looks like on x-ray. They have these wires in here that are metal that hold their chest closed forever afterwards, okay? So this is our FAST. Pretty underwhelming, okay? There's no big fluid anywhere. Jeff, this is something I would call you for 100 times out of 100, okay? So, normal study, we have the x-ray that was shown. There's clearly a nail sitting somewhere right near that heart. There's no effusion anywhere, okay? Somebody calls cardiac anesthesia and they come and they do an echo through the esophagus now, which is way more accurate than just through the skin, especially if somebody had that surgery before, right? So now we get our fancy echo and it's still negative. So He probably missed his heart. I mean, chances are. Still have to take the nail out, okay? I don't know anybody who would feel good enough, in spite of all of those negative studies, to just sit and pull it out in the ER. You know, no way. So that patient was taken to the OR, got big surgery, to take out the nail. Oh, here you go. There it is. Nail. Everyone see that? That's exciting, huh? That's why I like this job. It did no damage, PS. Yay, he should go play the lottery. I tell patients that all the time. Some of them should definitely go play the lottery. So here we go. This is kind of how we make our decisions. When you bring patients into us with big penetrating injuries that are somewhere in that box we talked about, right? Clavicles, nipple line, diaphragm, both anterior and posterior, right? Very important. If the patient is not stable, like really not stable, lost their vitals, we'll talk more about that in a minute. But they get surgery, okay? If they are stable, they can get way more workup, okay? If they're stable, they can get an echo, they can get much smaller incisions, they can get CAT scans if needed, although they're not great for things like that. So again, unstable OR, stable, we have more time, more workup, more time to play. It's like your stay and play or load and go. Same thing in the trauma bay. We either stay and play or we load and go, and we go up to the OR. I'm trying to like check with the chat at the same time. Yes, okay. I want to make sure I'm not missing any questions or anything. All right, moving on. We got a couple more to go. Motor vehicle crash, not belted, city speeds. Stable patient, right? Heart rate's 80, blood pressure is 135/60, respiratory rate's 28. He's got breath sounds, he's awake, he's alert, he can talk to us. He's got no obvious hemorrhage. So, blunt trauma, stable patient. We get our pictures, right and left side of the chest. Same or not the same? Yeah, they look the same to me. Heart? How many people think heart's normal? Normal? All right. Any blood on the right side? That's a no. No obvious blood in the pelvis. Again, this is just very full bladder. And no obvious blood on this left side either, okay? Left side is always the hardest picture to get, just FYI, because spleen and kidney both live really high, very posterior, and behind the rib cage. So trying to get your ultrasound to actually transmit its little ultrasound beam between the ribs to try and avoid rib shadows is a challenge. So that's always the hardest one. You never get great pictures, okay? But you can see kidney right here, and then spleen's right here, okay? Okay, so there's nothing obvious on FAST, but we cannot base our decisions to discharge patients on FAST. That's not enough. FAST is great for telling us if we have to emergently go up to the operating room. It is not great for telling us, okay, no, everything now is totally fine, because all it sees is fluid where it's not supposed to be. That's what it shows us.
There's a question that says, do you ever ultrasound posteriorly?
Good question. I'm gonna sort of guess what you're thinking a little bit and try and answer this. And I think that question probably came from my saying where the spleen and the kidney are. So when we do our pictures, when we take our pictures, when you're going right upper quadrant, you go kind of mid ish axillary line on the right side. Okay, that'll get between your liver and your kidney. When you do the left side, we actually ultrasound fairly posterior. So when we teach it, we tell people to hold the probe in their hand, reach over the patient's body, and put their knuckles on the bed. That's how posterior you want to be. Okay, and then you want to kind of aim up into the body. So you do get posterior way more on the left side to try and see that space. Did that answer the question? Yeah, okay, that was your question. Perfect. So yes, and more on the left side than on the right side. Yes, we do. So, okay, so back to our stable blunt trauma patient where the FAST is negative. That just tells us that there's not a ton of blood somewhere where it's not supposed to be, but it doesn't tell us that nothing's injured. So those patients then go to CAT scan because there is a ton that FAST doesn't see, okay? It doesn't tell us much about the retroperitoneum at all. And there's a lot of big important stuff in the retroperitoneum, right? Right. It doesn't tell us about solid organ injuries that don't lead to free fluid within the body, right? Both the liver and the spleen are contained in their own respective capsules, as are the kidneys. So they could still have a lot of injuries as long as the capsule's not broken. You're not going to see that fluid floating around. So we do still need to figure out what actually is injured on these patients, and so they go to CAT scan. Any questions about that? Chat box? No. Okay. And I think this one is my most important take-home point for you guys. So before I really talk about it, how many of you have brought us, and I really want hands here, so either e-hand or turn your camera on. How many of you have brought us to Sinai, if you remember, or really any of the hospitals, a traumatic cardiac arrest? Some, not a ton. Okay. Let me look at my e-hands here and see if I missed anybody. All right, so only a few of you. So of those who have brought you guys, of those of you who have brought us traumatic cardiac arrest, how many of you have been there when we've called time of death within a minute of you rolling into the trauma bay? Anyone? I have at least one. I see Jeff. Jeff was a yes. Whoever SL is a yes. Okay. Do you know why we do that? Harold is a yes. I mean, I got to tell you, if I was EMS, I feel like, and I put all this time and effort into really like trying to resuscitate somebody, and I bring them into the trauma bay, and within like, you know, a minute or two, the patient's pronounced dead, I feel like I would be frustrated about all of the work that I put in.
I think it's just there, you can confirm there's no cardiac activity.
Correct. And I think that's super important, right? So there's things, you know, you can see PEA on monitors, you know, you can see those kinds of things. But if a patient has no cardiac activity on FAST or on ultrasound, even if their downtime has only been 3 minutes, 4 minutes, the chance of any meaningful recovery, meaningful meaning neurologic also, is 0%. Okay, 0%. And so that's the first thing that we do when any kind of traumatic arrest, no matter if it's penetrating or blunt, rolls into the trauma bay. If there is no motion on ultrasound, we call it. That's a bit of a change. In the past, it used to really be based on time, and we were much more aggressive with penetrating injuries than with blunt injuries. And I think we're still more aggressive in terms of like surgical intervention with penetrating injuries than blunt injuries because they have a higher chance of survival. The best being, you know, our isolated stab wounds to the heart. It's low velocity. They have like a 50% chance of survival if they, you know, arrest in a timely fashion, if they're kind enough to arrest in front of us we can fix that. But that's a lot of what we do. So the ultrasound becomes very important to us in any kind of arrest. So penetrating trauma, patient's dead. So this is what we used to do. You know, it used to matter really how long since the injury and how long CPR is ongoing. And a lot of times these are a guess because if the patient's already in arrest by the time you guys get there, nobody knows a downtime. It's kind of just a guess. So again, if you look up, we have, I think EAST, do you guys ever use EAST guidelines or have you heard of that before? EAST is our trauma society. It stands for the Eastern Association for the Surgery of Trauma, I believe, and they've expanded to more than trauma. And I think they may even involve some pre-hospital stuff. Like they're the ones who came out with the first guidelines to not put C-collars on penetrating trauma patients. Okay, so they're like that guideline came from them that then became widely adopted. So EAST has guidelines and their old one used to be this time-based thing, right? More than 15 minutes of downtime or of a rest time, we would stop any resuscitation. Less than 15 minutes, you know, we would ultrasound, see if there's activity. If there's not, they're dead. These days, again, time doesn't really matter. So ultrasound is the first thing that we do for patients when they come in. So those are the cases I had for you. So I want to just say, so the EFAST, it is reliable and repeatable and easily repeatable, right, at the bedside. It is operator dependent, so very important that it's operator dependent, but it's a good rapid way for us to like try and make decisions about trauma patients. So with that, are there any questions about either anything I talked about tonight or anything else trauma related that you just happen to have a question about in general that I can answer? You can unmute or chat box or raise your hand.
Yeah, so I guess so that was really great. What a great, yeah, the practical the interaction, the pictures are spectacular. That's great. Thank you. What do you think about the role of this stuff in the field, right? Do you think is that something that you guys would advocate for, that leadership consider, or where do you guys stand with that?
I mean, I think it's a really interesting question. I think so that's why I kind of asked if you guys had butterflies already or if you're using them. And for those of you who don't know, the butterfly is an ultrasound that literally connects to an iPad or an iPhone. They're very fancy toys, but they're very cool. And then they're like, you just like take them around with you and you can ultrasound whatever you want. So, so very cool. But
if Sean would allow me to be more specific,
yeah,
the pulseless patient who is basically failed resuscitation and you're trying to make a decision to stop, it's not making the patient any better, it makes the provider feel better. Because we see a lot of those non-traumatic type of things in the field. My second question would be in some OB cases. If we're talking about a previa or an abruption, is that within, do you believe, a realm in the field, or is that a little too complex yet?
So I can answer the first. I thank God every day that my knowledge of OB is very limited, and so I will answer no questions about OB unless it's about a OB patient that gets in a car accident, in which case we can talk about that. But otherwise, for normal OB stuff, I try and have very little to do with that. If I'm involved, it's a problem. But for your other question, I don't know of any specific studies that have looked at outcomes after out of hospital cardiac arrest that wasn't traumatic based on cardiac activity. Okay, so at least the data that we use to support using FAST to stop our resuscitation is based on looking very specifically at trauma patients who no longer have cardiac activity. So I don't know, nobody would bring it into any kind of protocol for non-trauma patients because I don't know that that data exists. It probably could. I just don't know that there's any existing right now. But do I think it has a role for you guys for trauma patients in the field? I think it can, especially like, you know, especially Sean, correct me if I'm wrong, but aren't you like, there are specific, you guys have protocols that say that you can, like, you don't have to transport specific patients, right, after arrest?
Yeah, so there's definitely an update of the termination of resuscitation protocol for both medical and trauma patients in Baltimore County, and the time has gotten shorter.
And the time has gotten shorter, right? So I could see a world, and especially with more portable ultrasounds and stuff, where this gets incorporated into some of those algorithms. You know, I could definitely see that.
Yeah, I agree.
It may be partly time-based also, I would imagine. Like, I don't know if they'd be like, oh, patient like just arrested 2 minutes ago, and they'd say, okay, fine, call it. But, you know, if you get there, it's unknown downtime and there's no motion. I could see that being like a reason to not transport.
Everyone, there's a sign-in. Ashley sent around the sign-in sheet. It's in the chat. It's a bit.ly link /Feinman. So if you want your CEUs, take a look at the chat, click on that link and put in your information. So I did do a little bit of research prior to this talk, so excited. And I wanted to get a sense for what is the status of ultrasound in pre-hospital setting. Others on the line certainly may have other information that I don't know about, but what I found was a survey, ballpark 2015, looking at the US, and found about less than 5% of EMS systems were using ultrasound in the pre-hospital setting. It didn't provide any information. I suspect it's the more rural areas for sure. But the article did go on to say that it's probably one of the fastest growing technologies or use of equipment in the pre-hospital setting. So I think it's coming around. At Baltimore County, I haven't heard, in the medical director's office, I haven't heard much discussion about potential use of ultrasound. I've heard other things like video laryngoscopes and encouraging their use for sure, but I haven't heard much about ultrasound.
Any other questions from anybody? Again, this or anything else? And I'm kind of scrolling through the chat at the same time. Ari, I don't know who you are, but thank you for your comment for the as usual. So awesome.
Andrea had a question down there. Is there any conversation about early termination and it affects organ donation? Are they using the fast at all to decide if they will terminate versus life support for organ harvest?
That's such a good question. Oh my God. Okay. So, you know, we talk about this a lot too with our penetrating head injuries, right? Like in the trauma surgery world, there's always this debate, like if a patient has a penetrating head injury and they arrest, is there any reason to like open their chest up to do intracardiac massage and try and resuscitate them? And the people for it say, well, if you can get them back and they can be organ donors, that's great. And the people against it say, I mean, the reason that they arrested is because their head's not working, not because of their hemodynamics. So it doesn't make sense, right? So there's totally, there's always conversation for and against. I would tell you, especially because like the other part of my job and half of my job is being in the ICU all the time, that in order for patients to get to organ donation is a big process. Okay, so there's a few things that have to happen. Number one, the patient either needs to be designated, like on their license or something. If they designate, that's considered first person consent, and you go with that. If they're not designated, then family needs to be in agreement with, which in Baltimore in general is not super common. And it's very unfortunate that a lot of families think that if they agree to organ donation, then you're killing their family member. That's, you know, that's a thing, and it's hard to overcome, okay? But let's say they say yes, okay, and we make it to the point of yes, they're okay, and they want to donate organs, or the patient designated that they want to donate organs. It then takes days before they can actually donate the organs, okay? So they have to do 1 million blood tests and other tests, and they have to do like a bronchoscopy if they're going to donate lungs to look at the lungs, and they have to find matches, and they have to do all those things. And so the chance of, if we were using ultrasound in the field, okay, going back to that specific question, the chance of anybody going from like no cardiac motion in the field to being able to be an organ donor, I think is probably a 0% probability. Okay, I don't, because that whole process, even if you could somehow jumpstart their heart, and even if their brain's not going to have like any kind of meaningful outcome, so they could be an organ donor, they will never stay stable long enough to get them through all of that process to go be an organ donor. So I wouldn't worry so much about, like, if this ever got put into practice, you know, in the field, I wouldn't worry that like, oh my God, like we're not transporting somebody and they could have been an organ donor, because the chance of that happening is, I think, probably 0%. I feel like that was a lot of talking. Did that make sense? What about early termination in the ED? So that's what we use it for. Like early termination of the code, Andrea?
Yes, and the effect on, like, if you're going to resuscitate, and you're going to have a poor neurologic outcome, but you might be able to get back a viable enough that with pressors, et cetera, you could keep the person, you know, long enough for everybody to come say goodbye. And I mean, I worked at Trauma for a while, long enough that everybody can come say goodbye and get on the same page. There is something to be said for not there is something positive that can happen when we don't terminate as early. Again, it's not a rapid process. I used to spend a lot of time with Serena Nutter. It's not a rapid process, but it is another consideration of, not a downside, but another consideration of the termination, you know, making those decisions based on the fast, as opposed to once you've taken them to the OR.
Yep. I certainly hear the considerations. We definitely don't take that into account, you know, when we're deciding like what to do with the FAST exam we have. You know?
No, I didn't think you did. It was just actually more of, you know, an academic, if there has been any conversation between Donate for Life and East, or, you know, there any type of evidence looked at after the fact to see whether or not post-trauma, if there have been effects of using EFAST on organ donation or organ harvesting.
Yeah, not that I know of. I have never seen anything about that. I wouldn't even, you know, I'm not, maybe Dr. Barinholtz can help, because I'm not like the most robust researcher, but I don't even know if I would know how to set up a study to look at that. I think the N would be so small, you know, the number, that I don't know that we'd ever get really like good meaningful data. And that's really common in trauma in general. A lot of what we do ends up being based on anecdote, right? Because you can't randomize patients too often in trauma, right? So having randomized controlled trials that we would want in trauma is like almost non-existent. And then every patient is different and they all present differently. So to get a high enough like number of similar patients to actually look at outcomes in trauma is incredibly hard. So yeah, exactly. This would be totally anecdotal. But I've never asked like, you know, Living Legacy or anything if they have thought about it or talked about it, but they're floating around one of my patients right now, so I'll ask them tomorrow.
Somebody also shared that Anne Arundel, Queen Anne's in Dorchester has ultrasound programs in the pre-hospital setting. I don't know if Roger wants to add anything or know any more detail about who's doing it, under what circumstances, how's it's working out.
So hi, everybody. For those who don't know me, I see some of my own MSOP folks on the line here and some new faces. I'm the medical director for Montgomery County Fire Rescue, the associate medical director in Carroll County, and also the Region 5 medical director. So they're the hats I wear for medical oversight in the state. The protocol committee, some couple years ago, for MIEMSS, which meets regularly, had approved a pilot program for a ultrasound program in Queen Anne's County, if I recall first, and they were looking at using the FAST exam to enhance their knowledge of being mostly able to bump patients up in their category. So if they see blood, they would be able to sort of validate some of their suspicions. But if they don't see blood, they really didn't have the ability to use it to rule out anything so much as rule in. And I do also believe they use it for issues surrounding cardiac motion. So that was the first program to come on board. And then whenever you have a pilot program, MIEMSS does allow secondary jurisdictions to begin to sort of add. And I believe that the second one was Steve White, who has been the medical director of Tennessee, doesn't brag about it, down in Dorchester County had begun to investigate an ultrasound program and teach his medics. They have kind of a small span of control in each of those counties, so it makes it a little bit easier to make sure that their initial training is both good in the beginning, and also their medics are getting some exposure to using it on a more regular basis. And then finally, John Wendell, with the assistance of the associate medical director at Anne Arundel, who is a trauma anesthesiologist at Shock Trauma, has introduced a duty officer-based program so that they keep their span of control small in Anne Arundel County. Steve White went back to the protocol committee and actually asked for expansion of the indications, wanting to be able to increase the ceiling of what he's allowed to do. I don't have the protocol right in front of me, but it may include something that's less binary and more judgment calls, such as lung sliding, I believe is one of the things that Dorchester was looking into. And finally, we in Montgomery County are certainly exploring that, but we want to sort of have the indications fit our demographics, our scene time versus transit time. So we're looking at what we call the POCUS pulse, which is the idea of being able to, during PEA arrests, look at the presence of flow through the carotids. And while we're at it, I'm kind of a supporter of being able to look at the binary yes versus no cardiac motion. But the dilemma we have is, if we're going to be looking at flow as the ultimate arbiter, but whether you have a very low blood pressure that doesn't allow you to feel palpable pulses, that it may be more a direct algorithm to look right at the POCUS pulse rather than bother with looking at the wall motion. If you're gonna find that there's no flow, then do you really need to look at wall motion? And with that, I did have a question for the speakers, and maybe you, Sean, and that is, if you have a Lucas in place or CPR in progress, which of the views do you prefer? I don't know if the surgeons ever really have the Lucas in place, because if they're gonna do something about it, they're gonna open the chest. They're not gonna be doing closed massage. But if you had to guess, what's your vote on parasternal long versus subxiphoid view if you're trying to decide what kind of peaks you're gonna take during the pulse checks? Because one of the things we don't want to do is pause too long and defeat the purpose of high performance CPR. So that's what's going on in terms of the 3 jurisdictions I'm aware of. And the question I had was about parasternal long versus subxiphoid during arrest, either medical PEA or traumatic.
So that is a great question. The Lucas, when patients come in with it, certainly poses like a challenge for us, right? Trying to like work around it. So we definitely go subxiphoid if a Lucas is in place, because we can